Chapter 9 Anxiety Disorders and Anxiolytics. When is anxiety a disorder? Anxiety is a normal emotion under circumstances of threat and is thought to be a part of the evolutionary fight or flight reaction for survival. The idea of anxiety as a psychiatric disorder is evolving rapidly and is characterized by the concept of core symptoms of excessive or misplaced fear or worry. Anxiety disorders have a considerable symptom overlap with major depression, particularly sleep disturbances, problem concentrating, fatigue, and psychomotor or arousal symptoms. All anxiety disorders are also extensively comorbid with each other and have overlapping symptoms of anxiety or fear coupled with worry, and many patients qualify over time for a second or even a third concomitant anxiety disorder. As mentioned, worry is the second core symptom and is shared across the spectrum of anxiety disorders and is hypothetically linked to the functioning of CSTC loops, also known as worry loops. What differentiates one anxiety disorder from another is the specific nature of malfunctioning within the same circuits in various anxiety disorders. For example, in GAD, malfunctioning in the amygdala and CSTC worry loops may be persistent and unremitting and yet not severe. Whereas in panic disorder or social anxiety, the malfunctioning is intermittent but catastrophic. And in PTSD, the circuit malfunctioning may be traumatic in origin and conditioned. PTSD is also frequently comorbid with many other conditions such as substance abuse, ADHD, bipolar disorder, pain disorder, sleep disorders, and more. The amygdala and the neurobiology of fear. It's an almond-shaped center located near the hippocampus. It integrates sensory and cognitive informations and then determines whether there will be a fear response. This is regulated via reciprocal connections that it shares with orbitofrontal and anterior cingulate cortex. And the motor responses are regulated in part by the connections between the amygdala and the periaqueductal gray area of the brainstem. The endocrine reactions are in part due to the connections between the amygdala and the hypothalamus, causing changes in the HPA axis and thus of cortisol levels. Chronic and persistent activation of this aspect of fear response can lead to increased medical comorbidity, including increased rates of coronary artery disease, type 2 diabetes, and stroke. Breathing can also change due to the connections between the amygdala and the parabrachial nucleus in the brainstem. An accelerated respiratory rate when having a fight or flight reaction is to enhance survival, but in excess, this can lead to unwanted symptoms of shortness of breath, exacerbation of asthma, and a false sense of being smothered. These occur especially during attacks of anxiety, such as panic attacks. The autonomic nervous system is attuned to fear and can increase pulse and blood pressure for fight and flight reactions. These responses are mediated by connections between the amygdala and the locus coeruleus, home of the noradrenergic cell bodies. Chronically triggered as part of an anxiety disorder, this can lead to increase in atherosclerosis, cardiac ischemia, hypertension, myocardial infarction, and even sudden death. Therefore, scared to death may not always be an exaggeration or a figure of speech. Anxiety can also be triggered internally from traumatic memories stored in the hippocampus and activated by its connection with the amygdala, especially in conditions such as PTSD. Thus, the processing of fear response is regulated by the numerous neuronal connections flowing into and out of amygdala. Each connection utilizes specific neurotransmitters. These neurotransmitters are GABA, serotonin, norepinephrine, voltage-sensitive calcium channels, and anxiolytics that act upon these neurotransmitters. CSTC loops and the neurobiology of worry. Dopamine and born worried. The second core symptom of anxiety disorder is worry and involves another unique circuit, CSTC feedback loops from prefrontal cortex. Symptoms of rumination, obsessions, and delusions are all types of recurrent thoughts. Neurotransmitters that regulate these circuits include serotonin, GABA, dopamine, norepinephrine, glutamate, and voltage-gated ion channels. Various genotypes of the enzyme COMT regulate the availability of dopamine in the prefrontal cortex and may impact the risk of worry and anxiety disorder and help to determine whether you are born worried. Warriors versus worriers. Normal controls with the MET variant of COMT have more efficient information processing in the DLPFC. During cognitive tasks, they have lower COMT activity and higher dopamine levels. But with the MET genotype, stresses can hypothetically produce too much dopamine activity, which actually causes insufficiency of information processing under stress and create the symptoms of anxiety and worry, that is, warriors. Under stress, valve carriers of COMT with their higher enzymatic activity are hypothetically able to handle the stress better. GABA and benzodiazepines. GABA is one of the key neurotransmitters involved in anxiety and has regulatory role in reducing the activity of many neurons. And benzodiazepines act by enhancing GABA actions at the level of the amygdala and prefrontal cortex within CSTC loops to relieve anxiety. As discussed in previous chapters, GABA is synthesized from the amino acid glutamate via the action of enzyme glutamic acid decarboxylase and is transported via vesicular inhibitory amino acid transporter into synaptic vesicles, as is shown in this slide. And its actions are terminated by the presynaptic GABA transporter, also known as the GABA reuptake pump, and the enzyme GABA transaminase. There are three major types of GABA receptors and numerous subtypes. The three major types are GABAA, B, and C. A and C receptors are both ligand-gated ion channels and form an inhibitory chloride channel. GABAA receptors are targets of benzodiazepines, sedative hypnotics, barbiturates, and alcohol. The role of GABA-C receptors is not well clarified yet. And GABA-B are G protein linked receptors and may be coupled with calcium or potassium channels and may be involved in pain, memory, mood, and other CNS functions. GABA-A receptor subtypes. Each subunit of GABA-A receptor has 4 transmembrane regions. When 5 such subunits cluster together, they form an intact GABA-B receptor with a chloride channel in the center. There are many different subtypes depending upon which subunits are present. Subunits of GABA-A receptors are sometimes also called isoforms and include alpha, beta, gamma, delta, epsilon, pi, theta, and rho. And as stated, depending upon which subunits are present, the function of GABA-A receptor can vary significantly. Benzodiazepine-insensitive GABA-A receptors. These GABA-A receptors are those with alpha 4, alpha 6, gamma 1, and delta subunits. But these receptors do bind to other modulators, namely the naturally occurring neurosteroids as well as to alcohol and to some general anesthetics. The binding sites for these modulators is located between the alpha and the delta subunits. One site per receptor complex called the allosteric site. And 2 molecules of GABA bind per receptor complex at site located between alpha and the beta subunits, sometimes referred to as the GABA agonist site. These GABA-A receptors are located extrasynaptically and mediate a type of inhibition at the postsynaptic neurons that is tonic, in contrast to the phasic type of inhibition mediated by the postsynaptic benzodiazepine-sensitive GABA-A receptors. The tonic inhibition may be regulated by the ambient levels of extracellular GABA molecules that have escaped presynaptic reuptake and enzymatic destruction. The tonic inhibition is thought to set the overall tone and excitability of the postsynaptic neuron, and to be important for certain regulatory events such as the frequency of neuronal discharge in response to excitatory stimulus. Anxiety itself may be in part be dependent upon having the right amount of tonic inhibition in key anatomical areas such as the amygdala and the cortical areas of CSTC loop. If this tone becomes dysregulated, abnormal neuronal excitability could become a factor in the development of various anxiety disorders. Benzodiazepine-sensitive GABA-A receptors. In these, there are 2 beta units plus a gamma unit of either gamma 2 or gamma 3 subtype plus 2 alpha units of the alpha 1, 2 or 3 subtype. Benzodiazepines appear to bind between the regions of the receptor between the gamma and alpha subunit. 2 molecules of GABA bind per receptor complex between alpha and beta units. These are thought to be postsynaptic in location and to mediate a type of inhibition that is phasic. Benzodiazepines acting on alpha 2-3 exerts an anxiolytic effect due to enhancement of phasic postsynaptic inhibition. Receptors with alpha 1 subunits may be most important for regulating sleep and are the pre-assumed targets for numerous sedative hypnotic agents. But currently available benzodiazepines are non-selective for GABA-A receptors. Abnormally expressed gamma 2, alpha 2 and delta subunits have all been associated with different types of epilepsies. Benzodiazepines as positive allosteric modulators or PAMS. Interestingly, drugs that do not have benzodiazepine structure also bind to the benzodiazepine receptor. Thus, the benzodiazepine site is called the GABA-A allosteric modulator site, and anything that binds to this site, including benzodiazepines, are called allosteric modulators. Acting alone, GABA can increase the frequency of opening of the inhibitory chloride channel. With benzodiazepine, this frequency increases. As the benzodiazepines are PAMs, when they bind to the allosteric modulator site, they have no activity if GABA is not simultaneously binding to its agonist sites. This action can be reversed by the natural antagonist flumazenil, but which can also induce seizures or withdrawal in patients dependent on benzodiazepines. Benzodiazepines as anxiolytics. Benzodiazepines can modulate excessive output from the amygdala during fear response in anxiety disorders by enhancing the phasic inhibitory actions, and also the excessive output from worry loops by enhancing the action of inhibitory interneurons in CSTC circuits. Alpha-2 delta ligands as anxiolytics. Gabapentin and pregabalin are also known as alpha-2 ligands since they bind to the alpha-2 subunit of presynaptic N and PQ voltage sensitive calcium channels and block the release of excitatory neurotransmitters such as glutamate. They open overly active voltage sensitive calcium channels in the amygdala to reduce fear and in CSTC circuits to reduce worry. They have demonstrated anxiolytic actions in social anxiety disorders, panic disorders, and are also proven to be effective for the treatment of epilepsy and certain pain conditions, including neuropathic pain of fibromyalgia. They have a different mechanism of action as compared to SSRIs, SNRIs, or benzodiazepines, and thus can be useful for patients who do not do well on these. Serotonin and anxiety. Symptoms, circuits, and neurotransmitters linked to anxiety disorders overlap extensively with those for major depressive disorder. Thus, it's not surprising that leading treatments for anxiety disorders today were originally developed as antidepressants. Serotonin is a key neurotransmitter that innervates amygdala as well as the elements of CSTC circuits. Antidepressants that can increase serotonin are also effective in reducing symptoms of anxiety and fear in every one of the anxiety disorders. And not surprisingly, these agents include SSRIs as well as SNRIs. The 5-HT1A partial agonist buspirone is recognized as a generalized anxiolytic, but not as treatment for anxiety disorder subtypes. Its potential anxiolytic actions are due to both presynaptic and postsynaptic 5-HT1A receptors, resulting in enhanced serotonergic activity in projections to CSTC circuits. The onset of anxiolytic action for buspirone is delayed by virtue of adaptive neuronal and receptor events rather than simply by the acute occupancy of 5-HT1A receptors as do benzodiazepines. Noradrenergic hyperactivity in anxiety. Excessive noradrenergic output from locus coeruleus can also trigger numerous central symptoms of anxiety and fear such as nightmares, hyperarousal, flashbacks, and panic attacks, which reduces the efficiency of information processing in prefrontal cortex and thus in CSTC circuits, causing worry. This is mediated in part by excessive noradrenergic input onto alpha-1 and beta-1 adrenergic postsynaptic receptors in the amygdala. Symptoms of hyperarousal such as nightmares can be reduced in some patients with alpha-adrenergic blockers such as prazosin, and symptoms of fear and worry can be reduced by norepinephrine reuptake inhibitors. The effects of NET inhibitors can be confusing because symptoms of anxiety can be made transiently worse immediately following initiation of SNRIs or selective NET inhibitors, when the noradrenergic activity is initially increased, but over time they downregulate and desensitize postsynaptic NE receptors. When the noradrenergic activity is initially increased, but over time they downregulate and desensitize postsynaptic NE receptors, such as beta-1 receptors, and actually reduce symptoms of fear and worry. Fear conditioning versus fear extinction. If two stimuli are coupled, we learn to associate one with the other. Fear is learned during stressful experiences associated with emotional trauma and is influenced by individuals' genetic predisposition, as well as by the individual's prior exposure to environmental stresses that can cause stress sensitization of brain circuits. Some fears are crucial for survival. However, other fears that are learned and not forgotten may hypothetically progress to anxiety disorders. PTSD, panic attacks are all forms of learning known as fear conditioning. The amygdala is involved in remembering the various stimuli associated with a given fearful situation by increasing the efficiency of neurotransmission at glutamanergic synapses at the lateral amygdala. Sensory inputs about those stimuli comes in from the thalamus or sensory cortex. This input is then relayed to the central amygdala, where fear conditioning also improves the efficiency of neurotransmission at other glutamate synapses there. Both synapses are restructured and permanent learning is embedded into the circuits by NMDA receptors, triggering long-term potentiation and synaptic plasticity, so that subsequent input from the sensory cortex and thalamus is very efficiently processed to trigger the fear response as output from central amygdala. Input to the lateral amygdala is modulated by the VMPFC and the hippocampus. Now, if the VMPFC is unable to suppress the fear response at the level of amygdala, fear conditioning proceeds. And the hippocampus remembers the context of the fear conditioning, making sure fear is triggered when the fearful as well as all the associated stimuli are encountered. Most of the contemporary treatments for anxiety and fear act by suppressing the fear output from the amygdala, and therefore they are not cures since the fundamental neuronal learning remains in place. Novel approaches to the treatment of anxiety disorders. There are two ways to neutralize fear conditioning. First is facilitating a process called extinction, or by blocking a process called reconsolidation. Fear extinction is the progressive reduction of the response to the feared stimulus and occurs when the stimulus is repeatedly presented without any adverse consequences. Rather than reversing the synaptic changes, a new form of learning with additional synaptic changes in the amygdala occurs during fear extinction. These changes can suppress symptoms of anxiety and fear by inhibiting the original learning, but not by removing it. This sets up a gate within the central amygdala, with fear output occurring if the fear conditioning circuits predominates and no fear output occurring if the fear extinction circuits predominates. The output depends upon which system is stronger, is better remembered, and has the most robust synaptic efficiency. Fear extinction appears to be more labile than fear conditioning and tends to reverse over time. Also, fear conditioning can return if the old fear is presented in a context different than the one learned to suppress, a process termed as renewal. CBTs that use exposure techniques come closest to facilitating fear extinction, but such therapies are often context specific and do not always generalize once the patient is outside. Thus, fear and worry may be renewed in the real world. Specific drug might also strengthen extinction learning by pharmacologically strengthening the synapses on the fear extinction side. NMDA receptor activation at the very time when the patient receives systematic exposure to feared stimuli, either with direct acting agonists such as D-cycloserine or with indirect glycine enhancing agents such as selective glycine reuptake inhibitors. During CBT, learning occurs because glutamate release is provoked in the lateral amygdala and in the intercalated cell mass at inhibitory GABA neurons by psychotherapy. If NMDA receptors at these two glutamate synapses could be pharmacologically boosted to trigger disproportionately robust long-term potentiation in synaptic plasticity, exactly when these synapses are selectively activated, it could theoretically result in the predominance of extinction pathway. Reconsolidation. Blocking reconsolidation is a state in which reactivation of the consolidated fear memory makes it labile and requires protein synthesis to keep the memory intact. Beta blockers disrupt reconsolidation of fear memories as well as formation of fear conditioning. Treatments for anxiety disorder subtypes. Generalized anxiety disorder. As stated before, the treatments overlap greatly with those for other anxiety disorders as well as depression. The first-line treatments include SSRIs, SNRIs, benzodiazepines, buspirone, and alpha-2 ligands. Some prescribers are reluctant to give benzodiazepines, but these can be useful when initiating SSRIs or SNRIs since these serotonergic agents are often activating, difficult to tolerate early on, and have a delayed onset of action. In other patients, benzodiazepine can be useful to top up an SSRI or SNRI for patients who have experienced only partial relief or when the symptoms surge and sudden relief is needed. Both benzodiazepines and alpha-2 ligands can have a role as augmenting agents. Failure to respond to first-line treatments can lead to trials of sedating antidepressants such as mirtazapine, trazodone, tricyclic antidepressants, or even sedating antihistaminics such as hydroxyzine. The vilazodone can also be considered as second-line agent. Adjunctive treatments include hypnotics for continuing insomnia, atypical antipsychotics for severe refractory or disabling symptoms unresponsive to aggressive treatment, and cognitive behavior therapy. Panic disorder. Panic attacks occur in many conditions, and first-line treatments include SSRIs, SNRIs, as well as benzodiazepines and alpha-2 ligands. And as previously discussed, benzodiazepines are often used as second-line during treatment initiation, for emergent use during acute attack, and for incomplete response. Second-line treatments include antidepressants such as the TCAs, mirtazapine, trazodone, which can be helpful in some cases and are occasionally used as augmenting agents to SSRIs or SNRIs. The MAO inhibitors are a good option for the treatment of panic disorder and should be considered when first-line agents and various augmenting strategies fail. And CBT can be an alternative or augmentation to pharmacological approaches. Social anxiety disorder. SSRIs, SNRIs, and alpha-2 ligands are certainly first-line therapies, but the utility of benzodiazepine monotherapy for first line is not generally as widely accepted as might be for GAD or panic disorders. Few noteworthy differences from other anxiety disorders. Also, there is less evidence for utility of older antidepressants and sedating antidepressants such as mirtazapine and trazodone. Beta blockers, sometimes with benzodiazepines, can be useful for some patients with very discrete type of social anxiety, that is, performance anxiety. Adjunctive treatments can also be naltrexone and acamprosate, since many patients may discover the utility of alcohol in relieving their social anxiety. And CBT can be a powerful intervention, sometimes even better than drugs. Post-traumatic stress disorder. SSRIs and SNRIs are proven effective and are considered first-line treatments, but often leave the patient with residual symptoms, including sleep problems. A unique treatment is the administration of alpha-1 antagonists at night to prevent nightmares. Preemptive treatment can be with beta blockers or opioids, and exposure therapy is perhaps the most effective among psychotherapies.